Good afternoon all. Welcome to our Friday free webinar. Today's webinar will be a rerun of one of our previously popular sessions on wound management. As today is a public holiday for Good Friday, we are presenting this recorded session. Please note that we do not have any Q&A session today. Thank you once again for joining us. I'll start the webinar now.
Which speaks about service excellence skills. That is nothing but for a healthcare professional to kickstart the journey in the healthcare sector. We usually cover the modules like like professionalism, healthcare communication, and infection prevention and control basics. All those and so on. The modules are covered over there. And the second stage is about core patient-centric skills. That is about, we usually say, we transform the healthcare professional from the competence level to the clinical expert level. And in the stage 3, it is about the specialization skills. For example, we have labor room upskilling program, ER upskilling program, clinical instructor program, and infection control nurse course program, and infection control and prevention for all the healthcare. So then the fourth stage, which talks about the leadership skills, that is about, one, we have the nursing leadership, another one is the healthcare management. And this is all about our skills for Med logo. And this is a quick announcement about the healthcare administration. The seats are getting filled so fast. So this is the last chance. Here's a QR code on your display. You can scan this QR code and register yourself for this program. And this is going to be a crash course type. I know, like, all the healthcare professionals.
Sorry for the obstruction. I will start once again.
Excellent skills. That is nothing but for a healthcare
I'm sorry, we are finding some technical glitch. I will directly start with Dr. Pari's presentation on wound management.
Glad to be back here on a Friday afternoon. And again, thank you for all of you for signing up and showing up for this session. This is something of a home ground for me because being a surgeon, wound care is something which I do day in and day out. So I wanted to share the tips and tricks and other things which you can help you to take care of the wound of a patient so that it heals faster. So let me start sharing the presentation. All right. So today's agenda is first I'll talk about the concepts of wound care. Then we'll get into how to assess a wound. This is something which is often missed, and we will get spend a little bit of time on how to assess the wound. Then I'm going to talk about the time wound management protocol. I think this is a very important concept that has come recently. And I think everyone who manages a wound should be aware of this. And finally, we'll get into some practical tips and tricks while doing dressings, and also talk about the various dressings that can be used. So let's first talk about the concepts. So wound healing is a systematic process, and it starts with the whenever there is a wound, there is bleeding, and the first step is to stop the bleeding. The hemostasis is the first step, and next is the inflammation. So here the neutrophils are the main cells, the macrophages are just coming in. Then there is a proliferative phase where the fibrin, and where the wound was there, the fibrin plug turns into fibrin, which is the scar, and then the collagen elastin synthesis and the epithelial cells slowly start coming in. And the fourth is the re-epithelialization, that is the skin over the wound gets formed again. And finally, what takes months or years, the remodeling of the wound keeps going on for a long time. So this is the nature's answer for any wounds we get. And our role is to just promote and support the healing process. So many times, what we do as intervention actually opposes the healing process. So we should understand what are the things which actually promote and we should support the healing process. So this is a basic wound healing pathway. And the reason I put it up is to emphasize that nature does a fantastic job, and our job is to just support it to do the job, to get the job done. So the other important concept, it actually was recognized in the 1960s itself, but it took a long time for it to come to the mainstream. And this is the importance of moisture. It is very sad that even as of today, many of the persons who take care of the wound are not focusing on this aspect of wound care. It has been proven beyond doubt that humidifying the wound and the wound environment dramatically affects the wound healing process. It hastens it, it makes it much faster, it is less painful for the patient, and there are so many other advantages. On the other hand, when there is excessive exudate that leads to excessive moisture in the wound, then it leads to not a lot of hydration of the wound, which is not really a good thing. And this is causes damages to the surrounding skin. This is known as maceration, and that causes further ulceration. You would have seen in many patients who have colostomy and ileostomy this happening because of excessive moisturizing. You can see around the ostomies there is much further ulceration happening. So several terms like moisture retaining, moisture balance, and moisture supplying dressings have come into vogue. So you should understand the most important term you have to understand is moisture balance. Neither should it be too much, nor should it be too low. You need to keep the right amount of moisture for the wound to heal. And this is something which we can support so that the nature takes care of the healing process quickly. And there are several factors which affect wound healing, all of which we should aim to control. The blood supply is the most important thing, both the microvasculature and the macrovasculature. So if the patient has any arterial disease or venous disease, the wounds don't heal that well. And also pressure points, wherever there's pressure points, you must be well aware there are not pressure ulcers. But if anyone who's got a wound, you should make sure that that wound is not under any excessive pressure. And then neuropathy would lead to loss of sensation, and that's something which we need to be careful about. I already spoke about the venous disease, arterial disease, and systemic problems like diabetes, obesity also affect wound healing. So we need to see the patient as a whole, not just the wound, and make sure we control the other comorbidities and especially diabetes, and make sure that the wound is supported in its healing process. The other important factor to consider is there are totally separate set of sort of steps to take care of an acute wound versus a chronic wound. So what do you mean by an acute wound? Is an acute wound which will heal in 4 weeks. Normal surgical wounds will fall into this category. A wound that does not heal within 4 weeks is then termed as a chronic wound, and then your way in which you take care of the wound varies slightly, but the general principles are the same. So that's about the general concepts. I wanted to talk about that wound healing is a natural process. The body just needs support, and more importantly, we should not oppose the process. And then important concept is the moisture balance, very, very important. And don't forget about the systemic factors that can affect wound healing. So these are very important concepts. Glad to be back here on a Friday afternoon. And again, thank you for all of you for signing up and showing up for this session. This is something of a home ground for me because glad to be back here on a Friday afternoon. And again, thank you for all of you for signing up and showing up for this session. This is something of a home ground for me because being a surgeon, wound care is something which I do day in and day out. So I wanted to share the tips and tricks and other things which you can help you to take care of the wound of a patient so that it heals faster. So let me start sharing the presentation. All right. So today's agenda is first I'll talk about the concepts of wound care. Then we'll get into how to assess a wound. This is something which is often missed, and we will spend a little bit of time on how to assess the wound. Then I'm going to talk about the time wound management protocol. I think this is a very important concept that has come recently, and I think everyone who manages a wound should be aware of this. And finally, we'll get into some practical tips and tricks while doing dressings, and also talk about the various dressings that can be used. So let's first talk about the concepts. So wound healing is a systematic process, and it starts with the whenever there is a wound, there is bleeding, and the first step is to stop the bleeding. Therefore, hemostasis is the first step, and next is the inflammation. So here the neutrophils are the main cells, and macrophages are just coming in. Then there is a proliferative phase where the fibrin, where the wound was there, the fibrin plug turns into fibrin, which is the scar, and then the collagen elastin synthesis and the epithelial cells slowly start coming in. And the fourth is the re-epithelialization, that is the skin over the wound gets formed again. And finally, what takes months or years, the remodeling of the wound keeps going on for a long time. So this is the nature's answer for any wounds we get, and our role is to just promote and support the healing process. So many times, what we do as intervention actually opposes the healing process. So we should understand what are the things which actually promote and we should support the healing process. So this is a basic wound healing pathway. And the reason I put it up is to emphasize that nature does a fantastic job, and our job is to just support it to do the job, to get the job done. So the other important concept, that actually was recognized in the 1960s itself, but it took a long time for it to come to the mainstream. And this is the importance of moisture. It is very sad that even as of today, many of the persons who take care of the wound are not focusing on this aspect of wound care. It has been proven beyond doubt that humidifying the wound and the wound environment dramatically affects the wound healing process. It hastens it, it makes it much faster, it is less painful for the patient, and there are so many other advantages. On the other hand, when there is excessive exudate that leads to excessive moisture in the wound, then it leads to not a lot of hydration of the wound, which is not really a good thing. And this is causes damages to the surrounding skin. This is known as maceration, and that causes further ulceration. You have seen in many patients who have colostomy and ileostomy this happening because of excessive moisturizing. You can see around the ostomies there is much further ulceration happening. So several terms like moisture retaining, moisture balance, and moisture supplying dressings have come into vogue. So you should understand the most important term you have to understand is moisture balance. Neither should it be too much, nor should it be too low. You need to keep the right amount of moisture for the wound to heal. And this is something which we can support so that the nature takes care of the healing process quickly. And there are several factors which affect wound healing, that all of which we should aim to control. The blood supply is the most important thing, both the microvasculature and the macrovasculature. So if the patient has any arterial disease or venous disease, the wounds don't heal that well. And also pressure points, wherever there's pressure points, you must be well aware there are pressure ulcers. But if anyone who's got a wound, we should make sure that that wound is not under any excessive pressure. And then neuropathy would lead to loss of sensation, and that's something which we need to be careful about. I already spoke about the venous disease, arterial disease, and systemic problems like diabetes, obesity also affect wound healing. So we need to see the patient as a whole, not just the wound, and make sure we control the other comorbidities, and especially diabetes, and make sure that the wound is supported in its healing process. The other important factor to consider is there are totally separate set of sort of steps to take care of an acute wound versus a chronic wound. So what do you mean by an acute wound? Is an acute wound which will heal in 4 weeks. Normal surgical wounds will fall into this category. A wound that does not heal within 4 weeks is then termed as a chronic wound, and then your way in which you take care of the wound varies slightly, but the general principles are the same. So that's about the general concepts. I wanted to talk about that wound healing is a natural process. The body just needs support, and more importantly, we should not oppose the process. And then important concept is the moisture balance, very, very important. And don't forget about the systemic factors that can affect wound healing. So these are very important concepts to remember. Now let's get into how we assess the wound. So the wound, as all of us will be well aware, consists of these major features. It has got an edge, it has got a margin, and it has got a floor and also a base. So what is a floor? Floor is the exposed surface of the wound. So what you see on the surface of the wound is called the floor. And the edge is the area between the margin and floor. Okay, so the edge of the wound is the area between the margin and the floor. And the base is the surface on which the ulcer rests. So if the surface is a nice base, then the healing takes place faster. But if it's on for example, if it is on a bone, then especially in a place like the shin bone, the tibia, then the healing is impaired. And the margin is the junction between the wound and the normal epithelium. Okay, so that is the margin, and the edge is the area between the margin and the floor. So that is as we can say, the wall. The wall is the edge, and the margin is the area, normal skin and the wound area. So that is the margin. The first thing which I would talk about is wound measurement. As we talk in quality, and so also in wound care, what is measured is not improved. So many times we omit this part of management. We just keep doing the wound dressing and rely on your assessment, just eyeing the wound and assessing it whether it is increasing or not. Dedicated wound care professionals will frown upon this. So it doesn't take much of a time. So we need to capture it. Now, all of us have got mobile phones. So it's very easy to capture the wound, photograph the wound, and you can really see the difference happening over time. And then you measure to see the dimensions of the wound, record it meticulously in the patient's case sheet. By this way, you can monitor the healing progress. So it's very important to do this wound measurement. So how do you do the wound measurement? So when you measure, the first principle to remember is that the head is the 12 o'clock and the foot is the 6 o'clock. And this is the width of any wound. So when you measure head, that is from the head of the patient to the foot of the patient, it is the width of the wound. And then perpendicular to that, when you measure from 9 o'clock to 3 o'clock, that is the length of the wound. So people now will always get confused, which is the length and which is the width of the wound or breadth of the wound. So this is how you define what is the width and the length. So the length is from 9 to 3 and the width is from 12 to 6. So here you can see that the width is here, that is from 12 to 6, and the length is between 9 to 3. So this is the skin and that's the wound. Now, why this picture is put is because in an irregular wound, the widest part is actually the width of the wound. So you can see it's almost uniform. Here you can see here it is the width is the maximum. So this is the width you should record. The widest part of the wound is what you should record. And similarly, the the longest length is what you should measure. So that's why this picture is there. The other thing is the depth of the wound. Okay, so how do you measure all this? Is the culture and sensitivity stick, not the sterile stick which you take for culture and sensitivity. It has got a small cotton bed at the end. So by gentle probing of the wound, you can use this stick and a scale to measure these dimensions, the width, the length, and the depth or the height of the wound. And then we talk about the undermining. So what is undermining? So the undermining is the area of the ulcer under the skin. So there may be a flap of skin over the wound and this part is actually not exposed. So usually this can be missed and this is where the infection and other biofilms collect. So it's very important to understand what is the level of undermining. So you measure that in also. And finally, you also see if there's any tunneling. Tunneling is a deeper aspect, a small sort of tunnel from the base of the wound, and from the depth of this to the base of the wound is the length of the tunnel. So that's something, from the surface of the wound to the deepest part of the tunnel is the tunnel depth. So these are things you should measure when measuring the wound. Usually, again, length, breadth, and the depth is usually measured, but also see if there is any undermining or tunneling and also note down the measurements of these as well. Now, after the measurement, you've got to see what is the wound bed looking like. So this picture is very nice. It explains what are all the things which you can see in the base of the wound. So you can have very good healthy granulation tissue, or you can have slough, or you can see a bit of bone being exposed, or this is tenacious slough in the sense, this slough when you wipe it, it goes and go off. This will bond. So that is known as tenacious slough, and also the black dead tissue is known as the necrotic tissue. Any of these can be present in the base of the ulcer, base of the wound as well. Now, because of this difference in color, many people have tried to classify it based on the traffic light system. Unfortunately, the traffic light is inverted in the wound. Okay, you will see that. So the black is the necrotic part. Then the yellow or sometimes green is the infection and slough. And these are all things which are not good. And next it will become red if the wound is healing because of the granulation tissue, which is actually good. And finally, when the epithelium forms, it is actually a rosy pink in color. So many times I will find that a lot of patients come to my OP saying the wound is not healed for 3 months, like that. And what is happening is the wound is being subjected to a lot of trauma because when this epithelium grows, it looks like a faded white thing. People mistake it for slough and keep removing it. So the wound never heals. So all I'll do is put an occlusive dressing for a week, and no epithelium will not form. The body just does its job. And when the patient comes back and I remove the occlusive dressing, which is not disturbed at all, they just keep it for 4 days, then I'll renew it, keep it for another 4 days. Like that, if you do it, the wound will heal. And the patient thinks that you are such a magician. No, you did something that made the wound heal. But actually what we did is, we just left the nature alone to do its job. So you should know when to intervene and when not to intervene. Very, very important in managing a wound. Now, the next thing in a wound characteristic is the wound discharge or wound exudate. So we have several types of wound discharge. The serous is not very bad. Serous sanguineous is when there is mixed with blood. Purulent is what you should be looking at, and if it is purulent, then you should start worrying and start intervening. And sometimes there can be blood also in your dressing. So these are the different types of exudate. And some of the wounds are dry, they don't have any exudate. For example, diabetic foot wounds are very dry. Some have low exudates and some will have very high exudates. So your choice of dressing will depend upon the amount of exudate which comes from the wound. We'll talk about it more when we're talking about the dressing materials. So now you can understand all these are very, very important in assessing. Only when you assess, then you can manage. So next is the signs. So in an acute wound, it's the usual pain, that is the dolor, calor, rubor, and all those Greek terms. So basically, there will be pain, there will be warmth. You can see the redness. The edema will be there, so there will be swelling. And because of the pain, the patient will not be moving that part of the body. So these are the 5 cardinal signs of inflammation. So it's very easy to detect it in the acute wounds. But the chronic wounds is not like that. It's very, very difficult to detect infection because it goes on for a long time and the signs can be very subtle. So in chronic wounds, any one of these factors means there could be infection. So the healing is delayed or the granulation tissue is unhealthy. Though it is granular, it is not that bright red. It looks that unhealthy red. So that's an unhealthy granulation tissue. And then new areas of slough will start forming. The edge will start getting undermined. And then you can feel the malodor, the stink whenever you go near the patient. And sometimes the whole wound breaks down. It looks like it was healing, then suddenly when you open the dressing, now the whole wound is broken down. So these are all signs of infection. So be careful to note of these signs when you are taking care of a chronic wound. So that's about measuring at the wound and assessing the wound. Very important. So we saw how to measure and how to assess the various wound characteristics and also the exudates and how to identify the signs of infection in both acute wounds as well as chronic wounds. Now we are getting into the T.I.M.E protocol for managing wounds. So what is this? So basically, as I told you, wound management is the process of taking care of the wound. And we use both local interventions as well as systemic interventions to keep the wound healthy and to allow the healing process. Now, this protocol, T.I.M.E, was developed in 2002, beginning of this century by wound care experts. So it's not new. And there is a practical guide for managing patients. A spin-off of this is moist. One group was again redid this and call it moist wound management. We won't get into that. It's basically a very small change. They added oxygen into this. I feel it's basically industry. But T.I.M.E is a very good acronym to remember to manage any wound, both acute and chronic. So what is this? You will see T stands for tissue management. I for inflammation and infection control, M for moisture balance, and E for epithelial or edge advancement. You sort of do something to allow the edge to advance. So we look at it one by one. So in the tissue part of it, when you look at the wound, you ask yourself the question, is there any non-viable tissue in the wound? Are there any parts of the wound that is non-deficient and which needs to be replaced? So if the wound is very deep, if the wound is very large, then it's a deficient. It don't heal by itself. So you need to use grafting or other plastic surgery procedures to heal the wound. So it's very, very important to assess this, when you're looking at the T part. Look at the tissue, and as I told you, the various things like undermining, tunneling, signs of infection, the color of the base, all these gives indication about non-viability and whether the wound is deficient. Next, you look at signs of infection or inflammation. This already we touched upon. And M is for moisture. So is there too little moisture or is this too much of moisture? You should assess. Based on that, you will select your dressings. And E is the edge. So many times you can see like here, the edge will be overhanging and it is not flush with the wound, and thereby it is unable to grow. See, the epithelium can grow only the thickness flush with the granulation tissue. So here what we need to do, we need to sort of trim the edges so that it becomes flush and allow the epithelialization to take place. Or if it is unhealthy, then also you debride it. So the edge is very, very important because edge is from where the epithelial cells will grow to cover the wound. So the TIME is a very good acronym. The tissue, infection, moisture, and edge management is what we should do. So it applies both to chronic wounds and to acute wounds to prevent, so that acute wounds don't progress to chronicity. Now, I've tried to summarize the whole time wound management in one slide. We'll see whether you appreciate that or whether I've done a good job. So you have the necrotic, that is the black in the top, the infected, the white, the granulating, the red, and the epithelializing, the pink type of wound, which you need to manage. Now, very important to understand that you need to intervene for the necrotic and infected wound. Do not intervene for granulating and epithelializing wound. By intervening meaning don't do anything that will stop the process. Okay, here you have to kickstart the process. That is a necrotic and infected wound. You have to kickstart the process of healing. Here the healing is going on well. You should make sure you just support it. So intervene for the top two. Do not intervene for the bottom two. Now, in the tissue management, for the top two, you need to do debridement. You will do debridement either by chemical, enzymatic debridement, or physical. That means it's like a surgeon. I'll take the knife and take off all the necrotic tissue. And also you need to use the appropriate dressings based on the exudate. We will talk about it shortly. In the granulating and epithelializing wound, the present concept is called undisturbed wound care, UWC. Okay, this is a new terminology, relatively new. So undisturbed wound care means you just put an occlusive dressing and leave that wound alone. Do not try to do anything to it. Do not keep changing the dressing frequently and all this. So undisturbed wound care applies to granulating and epithelializing wound, and you should use the appropriate dressings for this purpose. So that is the tissue management. Infection, again, for the necrotic and infected slab, you need to use systemic antibiotics. You can use ointments. So basically, ointments are traditional ointments like mupirocin, any of those antiseptics which are used like betadine and other things, or you have some newly available ointments where hydrogels are impregnated with stem cells and other things. They're coming on the market. Very expensive, but that is supposed to stimulate wound healing. But anyway, whatever it is, you use both local and systemic measures for necrotic and infected stuff. If there is pus, you do incision and drainage. If there is necrotic tissue, debridement, or use the chemical debriding agents. All this, a combination of this is used to eradicate infection and to kickstart the healing process. In the granulating wound, none of these are required. Just leave the wound alone. Now that's what it very important to understand. Next is moisture control. So if there is a high exudate, you need to use an absorbent dressing, or you can use vac therapy where continuous low suction is used to take those discharge or exudate from the wound. If it is a low exudate, you put the appropriate dressing just to maintain the moisture and not to dry it out. In the granulating and epithelial wound also, moisture balance is very, very important. So that is why traditional dressings like gauze and G-pad for these wounds actually delays wound healing here. We need to use dressings that will maintain the moisture. And finally, age management, you need to debride it in the necrotic and infected wound. Here you have to protect the edge. The edge is healthy and it is trying to grow the epithelial cells. So make sure you protect the edge and make sure that they are not traumatized. So this is how you manage the using the time wound management protocol, these 4 types of wounds. These are the major types of wounds you will encounter in your clinical practice. So with that knowledge, let us get into how to select a dressing and how to do dressings for the wound. So dressing on the wound is a very simple procedure. You first prepare the equipment and all that which is needed for the dressing. I'm not going to go much into detail. And then prepare the skin around the wound so that you disinfect the skin around the wound when you do the dressing so that you don't contaminate the wound during dressing. Then you have to clean the wound and then press off. These are the 3 basic steps of doing a dressing. So how do you prepare? You need to disinfect the skin around the wound using appropriate antiseptic. Mostly povidone iodine is used. Sometimes people who are allergic to iodine, you can use chlorhexidine to disinfect, just like surgical and not skin disinfection. Make sure the betadine and other chemicals don't get into the wound. So that is important to prepare the skin around the wound while doing wound care. And cleaning, you can use several agents to clean the wound. These are known as irrigating agents. They include sterile or clean water and a Ringer's solution or saline solution. There are several others which are also used, like hydrogen peroxide, povidone iodine, alcohol, tincture benzoin. I still remember those painful times where they'll put tincture and put a cotton onto the wound. Whenever I get injured when I was a boy, and it will just get stuck to the wound. So every time we take it out, the epithelium will come off along with the cotton. And also acetic acid, 2% acetic acid is also used. Mainly they say it is good for Pseudomonas. But several studies have shown that all these agents, hydrogen peroxide, povidone iodine works only on intact skin. If you put it on any wound, that is organic tissue, it gets inactivated immediately. So it's not only is inefficient, it also it's toxic to the tissues. Again, same with alcohol. Tincture benzoin is again toxic to the wound as well as to the patient. Acetic acid, 1%, 2%. Judiciously, you can use whenever there is for chemical debridement or to get rid of the contamination. But it has to be for a very timed period. So most countries have banned all these agents, but in India, these are freely available. That's the tragedy. So it is self-control we have to use, and also lack of knowledge. Many people don't know that these are harmful. Because the seniors are using, they also continue using this. So the best thing is to use either saline or sterile water. Because in our country, tap water is not very clean. So we need to use sterile water or saline. And sometimes people say you can also use RO water. So these are not for chronic wounds. For acute wounds, definitely sterile water or sterile saline. Now, we are coming to the dressing part. Now, what is an ideal dressing? This is like any other thing. They will list a lot of characteristics and then say, as of today, such a dressing does not exist. So what is that? One very important thing is you should have humidity, okay? And also it should remove excess. You should have moisture balance. The dressing should not have toxic particles and it should protect the wound from further trauma. When you remove it also, there should not be trauma, both to the wound and to the patient. Okay, impermeable to bacteria. Maintain the temperature. Allow air to pass in and through. Should be comfortable, conformable to the joints and other parts of the body. Require infrequent changes and cost effective. That's the most important thing. And long shelf life. Okay. Many of the dressings actually will tick almost majority of boxes, except the cost effective, right? And especially the modern ones. So let's look at that. So wound dressing has to be trilaminar. So the trilaminar is the inner part, which is in contact with the raw area of the wound, should be non-adherent, meaning it should not stick to the wound. This is the non-adherent layer. Then you need a layer which can absorb the exudate. That is the absorbent layer. And then the third layer is the retaining layer. Very simply, if you're putting a Ganji pad dressing, you should put a paraffin gauze because paraffin is non-adherent. on the wound. That is the non-adherent layer. Then you put the Ganji pad, which has got a thick pad of cotton covered by gauze. That is the absorbent layer. And then you use a bandage or a tape to retain it. So this is simple. We are using it day in and day out. Trilaminate dressing is what we use day in and day out. And this is the principle behind it. So the non-adherent layer and absorbent layer are known as the primary dressing, and the retaining layer is known as the secondary dressing. So there are several wound dressings. We will classify them as traditional and modern. Traditional, we will classify them based on adherence. How badly or how well they stick to the wound, because when they stick to the wound, it's bad. So when the adherence is high, the gauze and cotton we use will get adherent. And every time you remove, there will be pain to the patient. It dries quickly, so it gets stuck to the wound and it does not retain or supply moisture. So low adherence is the paraffin and tolate. Now we use this paraffin gauze. You can either prepare it yourself or it is available commercially. So this is the traditional dressings we use for majority patients even now. So mainly because of cost and mainly because of ignorance, I think. Now the modern dressings, again, as I said, moisture is a very important aspect of wound healing. In the modern understanding of wound healing, we will classify them as moisture retaining and moisture supplying. So if the moisture retaining low or films, okay, I'll talk about it now also what films are, what foam is, and all those very quickly. So just go through this. So low moisture retaining are the films, high moisture retaining are the foam dressings. And there are dressings which will supply moisture to the wound, and these are the hydrocolloids, hydrogels, and the alginates. So these are the modern wound dressings. Now, let's look at it one by one. The films, you will be familiar with some of these trade names. 𝐼𝐴, Opside, Tegadam. None of this company are paying me any money for this lecture. But just for familiarity, I'm just telling, because many of us don't call it films. So these are, as you can see here, thin films. They may have some absorbent layer, or sometimes just thin film. And these are sterile plastic sheets of polyurethane coated with hypoallergenic. 𝐼𝐴 is one of the companies which makes these, and their adhesive is very, very good. And when we talk about moisture, we will talk about retaining moisture or supplying moisture. These dressings retain the moisture because it is an occlusive dressing, and also they can breathe. So many times the objection to use these films on patients, especially many surgeons, will say, in our country where there is so much of heat, you don't put occlusive dressing because the gauze and G-pad will breathe and this will not allow the wound to breathe. Not true. These plastic sheets are made in such a way they're actually micropores, and this will allow the air to move in and out. Okay, so it retains the moisture, but it is not supplying moisture. Absorbent is low. It is a very thin layer, if at all. And if there is a little bit of more exudate, it will lift off. So very low absorbent capability. So where all will you use it? Any clean wound with low exudate, you can use it. Typical example is post-operative wounds, skin aberrations, chronic wounds, on the leg and pressure ulcers, which are superficial, and also superficial burns. So these are areas we can use films. Now, hydrocolloid is actually, we can say, is the workhorse of the modern medicine. This can be used for almost any type of wound, as long you use it properly. So some of the trade names are duoderm, Comfil. Okay, so these could be any of these chemicals in combination: sodium carboxymethyl cellulose, gelatin, pectin, elastomers, and adhesives. These are bonded together and made into a film. See, like these sort of brown sheets you can see, right? In various sizes they are available, and they are again semi-permeable. They are flat and they will stick on the one. Very good advantage. You don't need anything to do that. Will stick on, and because of the warmth, it sticks more, and it forms a gel promoting moisture. Many times, because of the warmth, this gel will sometimes leak out of the dressing, and it can be mistaken for pus. It's actually the gel, which actually liquefies because of the body temperature. So it has got good retaining capability, moisture retaining capability, but it does not supply much of moisture. absorbency is moderate. No, to an extent it will absorb and liquefy. You can keep the dressing for 3 days, 4 days without changing it. And as I said, it is workhorse for most dressings. Most acute and chronic wounds that are not infected this can be used. Definitely, you can use it for granulating and epithelializing. This is the trick I was telling you in the beginning. To not make any healing wound is being disturbed often to heal. Okay, so that is the hydrocolloid dressings. Now, hydrogel dressings, some of the trade names are Resto, Aquodome, Suprasorb. So it is a matrix of polymers with 96%. Now, mostly it has got water content. So these dressings are very cool. It actually reduces the pain to the patient. And they donate water. No, I said not that moisture supplying the dressing, not the dressing, and maintains a moist environment. It is moisture retaining capacity, moisture supplying. It has got moderate absorbent capability. And this is mainly used in diabetic ulcers. It's a dry or sometimes ulcer with the slough which you want to de-slough. So, but not infected. And you can use, and if you leave them alone or if you put gauze or gamgee pad, they'll dry up. So when you put this hydrogel dressing, the moisture loosens the slough and they will come out. Okay, so pressure ulcers, cavity wounds, leg ulcers, graft and donor sites. So many times now you put the dressing on the donor side and you remove it will be very painful because paraffin gauze, even if you put, it dries up. Because those donor sites you won't remove it for almost 2 weeks. Okay, so you can use these. Diabetic ulcers, as I said, they are dry. You can also use it for post-op surgical wounds, lacerations and abrasions, as long as they are not infected. So that's about hydrogel dressing. Then is the alginate. Common trade names are calcistat, algicel, fibrocol. Now it is actually made from seaweed. Okay, it's the naturally occurring calcium and sodium salt. They absorb 50 to 20 times their weight in water. Very absorbent dressing. It will be like cotton candy. They come in large sheets or small sheets. So even when there is no large area which is bleeding, surgeons use it to actually control bleeding. Okay, so it can retain moisture, it can supply moisture, as you can see here, and it is very, very high absorbent capability. So it is used to stop bleeding in traumatic and post-operative wounds, bleeding from accidents, and actually it absorbs all the odor because seaweed, it absorbs all the odors from the wound, and it don't stink that bad, even in infected. And you can use it in dry wounds and infected wounds with high exudates. So this has to be changed frequently because these are high exudates, these are infected wounds, and use it to absorb the exudates and use it to give it moisture. So that's about alginate. And then foam is they call Alvin Life or permafoam. These are just a polyurethane or silicone foam, usually for very deep wounds, especially perineal wounds and all that can be deep. So you can just put the foam in place and they'll take the shape of the wound. Thereby, the absorption layer is large and it will prevent leakage of exudate outside. And then you can put a retaining layer and add a dressing. So they have retaining capacity. They don't supply moisture, but they're very absorbed. They take in a lot of exudate. So deep pressure wounds, deep ulcers, wounds with heavy exudates is what you use. So now we can see, if you know the characteristics of the dressing, you can choose your dressing according to the type of the wound, whether it's necrotic, sloughy or infected, granulating or epithelializing, and also based on the exudate, whether it is high or low. And also, very importantly, if the wound is infected or not. There are certain dressings which cannot be used for a long time. For example, hydrocolloid, you can't just put it for 3-4 days and then infect it. Okay, so with these 4 parameters, the type of the wound, the moisture, presence of infection, all these and the exudates, you can select the proper dressing. So quick word on WAT dressing. So they are also known as negative pressure wound therapy, NPWT, where you have a watertight seal on the wound, and then there is a tube which is connected to a motor which keeps continuously running 24 hours, 24/7. So what happens is the exudate keeps slowly coming out and gets stored in this reservoir. Thereby, not only the moisture is kept, the excess exudate is also taken off, and it causes dramatic, wound healing times. The wound edge will come together. These also can be kept for about 5 days to sometimes a week. And again, you have to be very selective in selecting the right wound for this type of treatment. So that brings me to the end of this talk on wound care and wound dressing. So let me summarize it. So as I said, we have necrotic wounds, infected or wounds with slough, granulating wounds, and epithelial wounds. So when you look at the tissue part of it, the top two, you need to debride and de-slough and make sure to eradicate infection, to make it prime it for healing. And then the granulating and epithelial wound is the undisturbed wound care. Don't disturb it. Just allow the nature to do its work. I is the infection part of it. Necrotic and infected will need systemic and local treatment, antimicrobials, whereas the bottom two, granulating and epithelializing, do not need either local ointments or antibiotics. They definitely need the proper dressing. So there are also ointments which are, like hydrogel ointments are available. So if at all using ointments, use that type of ointment rather than some ointment with the antimicrobial, because those antimicrobials can actually harm the delicate epithelial tissue. M is the moisture. Moisture balance is the mantra. Depending on the exudate, we use absorbent dressing or moisture balancing dressing. For the granulating and epithelializing wounds, use moisture balancing dressing. That's just the right amount of moisture. And the edge management in the infected and the necrotic wounds, you will debride it, the edge, so that it becomes flush with the surface so that the epitheliums can start growing. In the granulating and epithelial wounds, that's already happening. So make sure they don't get traumatized. You protect the edge so that the epithelium will start growing. So that's the end of my talk.
Thank you so much for joining us.
The course price is actually 4,999. Attending to the orientation program will have the 1,000 rupees of offer. Batch 2.
For the certificates, as usual, you will be getting the email tomorrow with the feedback link. Thank you all for attending once again. Sorry for the initial technical glitch, but thanks for staying back and listening to our rerun of this webinar for today. Thank you once again.